Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, The Clinical Role of MicroRNAs in Cytogenetically Normal Acute Myeloid Leukemia. MicroRNA 155 upregulation independently identifies high-risk patients by Guido Marcucci et al. My name is Eliu Este, and I am a professor in the Division of Hematology at the University of Washington Medical Center and a member of the Fred Hutchinson Cancer Research Center, both in Seattle, USA. My oncologic specialty is acute myeloid leukemia. Selection of therapy for newly diagnosed acute myeloid leukemia, hereafter AML, requires a choice between standard and investigational therapy, the latter typically in the context of a clinical trial. Because the results of a trial are by definition unknown, the decision must rest on the likely outcome of standard therapy, such as 3+7. Even in patients aged 70 years or above, with performance status less than Zubrod 3, resistance to therapy, manifested by either failure to enter complete remission, hereafter CR, or by relapse from CR, rather than treatment-related mortality, is a major cause of therapeutic failure. Hence, assessing the probability of resistance with standard therapy is fundamental to management of AML. It is well known that the karyotype of AML blasts is the chief predictor of resistance. Karyotype is probably least informative in the large group of patients with a normal karyotype, in whom outcome with standard therapy plausibly ranges from long-lived remissions to failure to enter CR, despite surviving long enough to have done so. Recent years have seen the introduction of various tests that examine the presence or absence of genetic aberrations, most commonly mutations in AML blasts. These tests have significantly enhanced the ability to afford accurate prognoses in normal karyotype AML. It is generally acknowledged that testing for mutations in the NPM1 and CEBPA genes and for internal tandem duplications in the FLT3 gene should be part of the initial evaluation of newly diagnosed AML. Normal karyotype patients with an NPM1 mutation without a FLT3 internal tandem duplication or with mutations in both alleles of CEBPA have prognoses similar to patients with favorable cytogenetic abnormalities, and are so classified in the European LeukemiaNet system. Accordingly, such normal karyotype patients are considered appropriate for induction with 3+7 and for post-remission therapy with high-dose cytarabine, but without allogeneic hematopoietic cell transplant, since their low risk of relapse does not warrant the complications associated with transplant. In contrast, normal karyotype patients with FLT3 ITDs, internal tandem duplications, are apt candidates for investigational therapies, particularly those combining hematopoietic cell transplant with FLT3 inhibitors such as quizartinib. The amount of prognostic information provided by NPM1, FLT3, and CEBPA can be quantified using the area under Receiver Operating Characteristic Curves, AUC, where an AUC of 1 denotes perfect prediction and an AUC of 0.5 a coin flip. Preliminary analyses suggest that inclusion of cytogenetic and FLT3 data yield an AUC for resistance, that is, no CR or relapse within 1 year of CR, of approximately 0.7, that is, closer to a coin flip than certainty. Although awaiting confirmation, a study from the Eastern Cooperative Oncology Group suggests that prognostic accuracy is likely to be improved by integrated analyses of aberrations in genes such as IDH1, IDH2, TET2, DNMT3A, ASXL1, PHF6, WT1, and MLL. Nonetheless, different reports often do not agree on the prognostic effect of a given mutation, for example in WT1 or IDH1. One possible explanation is that the effect of a given mutation may depend on the presence or absence of other mutations. A second explanation invokes differences in the downstream effects of a given genetic abnormality, and in particular, whether the abnormality is expressed and eventually translated into protein. Expression is regulated by DNA methylation patterns in AML blasts, as well as by expression of various microRNAs. As noted by Marcucci et al. In the current paper, microRNAs hybridize to target messenger RNAs, thereby preventing their translation into protein. Studying microRNA 155 expression in 363 patients with newly diagnosed normal karyotype AML treated on various cancer and acute leukemia group B protocols, generally employing standard therapy but without transplant in first remission, Marcucci et al. Found that higher expression was associated with an approximately 50% reduction in odds of CR, a 60% increase in probability of death, and in patients under age 60, a twofold reduction in disease-free survival, a reliable measure of therapeutic resistance. Several points bear emphasis. First, the patients studied for microRNA 155 expression had similar outcomes as patients treated on the same CLG protocols but not studied, suggesting the former were a representative population. Second, follow-up is long, median of 7.9 years. Third, the effect of microRNA 155 expression was independent of many of the genetic abnormalities noted previously in this podcast. And finally, the deleterious effect of higher expression was limited to the European Leukemia Net's favorable group in younger patients, age less than 60, and to its favorable and intermediate one group in older patients. The authors note that the assay used to quantify microRNA 155 expression is readily adaptable to routine clinical use. Hence, it is not difficult to see Marcucci et al.'s paper as a harbinger of a time when AML patients will be tested both for a range of genetic abnormalities and, relevant to the abnormality's downstream effects, profiled for DNA methylation, mRNA, microRNA, and protein expression, the latter known as proteomics. While many of these tests will likely be redundant, several benefits can be anticipated. First, probability of resistance to standard therapy will be much better delineated, enabling physicians to better choose between standard and investigational therapy. In the perhaps unlikely event that area under the curve can approximate 1, it might be possible to dispense with trials randomizing patients between standard and investigational therapy, since a given patient's response to the former will be largely predictable. However, it is important to note that currently, most unfavorable prognostic factors in AML tell us not to give standard therapy, but do not tell us what therapy to give, aside from transplant and possibly FLT3 inhibitors. However, to date, while transplant may somewhat improve outcome in poor-risk patients, the same prognostic factors, for example, the unfavorable effect of FLT3 internal tandem duplications, seem to apply with transplant and chemotherapy. It is likely that discovery of new molecular markers will simultaneously suggest new therapeutic targets. For example, as noted by Marcucci et al., inhibitors of microRNA will soon be available to overcome the effect of microRNA 155. These authors have also suggested that higher levels of microRNA 29b predict response to decitabine. Finally, we will become accustomed to thinking of AML as many diseases treated distinctively. The relatively small number of patients then receiving a given therapy may motivate a rethinking of conventional concepts of statistical significance and power. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.